this afternoon we have a fantastic presentation from the Jackson Laboratory, which we'll get to in a few minutes. I'm going to start today. I'm Roxanne Judah, I'm the Executive Director for the Wellness Council of Maine. I'm going to share just a little bit about the Wellness Council. Most of you are members of the Wellness Council that are here, but I would like to maybe refresh you with what we have done, but also some of the things that are coming up for 2015.
It's going to be really hard to sync them. I don't know if it's going to work.
The Wellness Council of Maine is a program of the Bangor Region Chamber of Commerce. It is the only program of the Chamber which represents about 22 of the communities here in the region that is also is a statewide program. Currently the Wellness Council represents all 16 of the 16 counties in Maine. We have members in every one of the counties. And actually technically have a couple in New Hampshire and one in Massachusetts. So we're really spreading. I don't really care to go New England, but I'm very proud that we are a statewide organization and that wellness is going on in all 16 counties in our organization. We were developed through the Bangor Region Chamber through a group of concerned members of the business community, and their goal was to advance and promote good health among employees statewide so that businesses can thrive and our economy can prosper. As we all have heard repeatedly, Maine has the oldest population in the country. And I recently met a demographer from Colby College who has looked at statistics from all over, and she informs me we are also growing oldest the fastest of any state in the country. And for those of us who have been in health promotion for any period of time, we recognize that lifestyle is a major contributor to how we age, how rapidly we age, how well we prevent disease, and how well we take care of ourselves and can continue to thrive independently and do the things that we enjoy. And part of that is being a good employee and being able to work in the kinds of occupations and that we care about. So what we do is very important work, and it's become even more critical to our economy here in Maine to make those changes and make those lifestyle connections for our employees. This is our timeline. We were started in about 2002. We were recognized as one of the first, the first well region in the country. That was about 2003 by WLCOA, which is the Wellness Councils of America. I actually had the privilege of speaking the other day with someone from Rhode Island. Rhode Island was recognized as the first well state in the nation. So she and I are going to work together and see how we can continue to spread the good word. There were a lot of similarities going on there between Rhode Island and Maine. In 2006, between 2006 and 2013, we became a statewide organization, kind of outgrew those 22 communities. They are still a big part of what we do, but we became much greater than that. And we developed a new national partnership with the National Wellness Institute. They are the oldest wellness organization in the country, and they hold the largest annual conference in the country in the summertime, and our members are certainly, they get discounts to attend that workshop, as well as discounts for their certifications as well. The National Wellness Institute provides all of our online resources. This is an example of the professional journal that they put out. There are free webinars which you can earn CECs for your certifications through them. They also have free archived webinars for trainings that you'd like to do with your staff on all different types of wellness activities and resources. They are affiliated with the University of Wisconsin, so their information is very educationally based, and we are very happy with the partnership. We are working with them to develop a national awards process, which would be rolling out this spring for organizations that would like to contribute to, who would like to apply for that award. It will give them national recognition on what they're doing with their employees. Currently, these are the members that support what the Wellness Council of Maine does. Anthem Blue Cross and Blue Shield is our premier sponsor. They're actually funding a small business program that we have right now for companies with under 100 employees. It's a starter program. If you have a wellness program that has either not taken off or stalled, it helps you with putting some pieces together to help take the thought and legwork out of it and help you get a good start in the right direction that is focused and sustainable for your organization. We have a new sponsor in Maine Health, which recently signed on as a gold sponsor. So the Wellness Council of Maine is supported by both major healthcare systems in the state. Our silver sponsors, the Jackson Laboratory, who we're going to hear from today, and Chimbro are strong leaders through the business community in representing wellness in their own organizations, and have a long history and have a lot to share with our members. Chimbro also will be represented tonight by Dr. Catlin in our panel as their Chief Medical Officer, so you'll get to hear about some of the wonderful things they do as well. These bronze sponsors down here, we currently have added Maine Community Health Options, and I think there's another one that I'm missing, and I apologize if I can't remember right now, but I just put them in today. These are, again, organizations that promote wellness, not only in their own organizations, but support what is going on throughout the state. They are a great resource for our members, because there's nothing worse than trying to figure out what you're doing with wellness. I always say it's better to be doing wellness than trying to figure out what to do with wellness. And that network really does help to provide our members with a lot of those answers that aren't easy to come across. We hold two major events that are statewide. This is from our September 24th event. It was our Leadership Summit Awards Luncheon. We recognized 4 leaders across the state, organizations who represented wellness throughout their region, in their organization, or even on a statewide basis with statewide recognition. This spring we'll be hosting a symposium. We're going to be hosting in the greater Portland area. I will give you date and time and venue as soon as we confirm it. Our events committee met yesterday, and we're nailing down those last minute pieces. We usually have a nationally recognized keynote speaker. Again, we have some exciting options that we're looking at for that as well. So look mid-March to mid-April, somewhere in that time frame. Hopefully it won't snow. Last year we did it on the first day of spring, and anybody who remembers, it was not spring-like. So we're hoping that we get to do something with some good traveling weather this time. Quickly, these are the organizations that we recognized. Some of you may recognize Healthy Main Streets. They were recognized for their statewide contribution to workplace wellness. They represented 19 communities across the state of Maine. We have Sheila Costello. This was Waldo County General Hospital. Their nutrition services program completely redid their nutrition plan, nutrition cafeteria, their cafeteria makeover. And it was a process that they shared with our membership and have made an incredible turnaround for their employees and what they provided within their meal plans. Penny Townsend is here with Chimbro. They were recognized for what they do with their give back to the community that's tied with their wellness program with Chimbro. And then we have Move and Improve, which is an EMHS program. And they are actually starting up. If you haven't heard of Move and Improve, it's been there for 19 years. It's an incredible program. It's very easy. It's wonderful for employees to sign up for and get an opportunity to get moving for 8 out of 12 weeks and earn possible recognition and prizes in that. I think in our newsletter we recently sent out the trainers' dates, times and locations, and there are all over the state. So this really can be a program that can be done anywhere in Maine. So I recommend, if you haven't looked at it, to take a look at Move and Improve. Just wanted to point out the challenges for Maine. Again, I think when we look at our economy and we look at our aging workforce, that's some of the things that we are here and working towards, and what the Wellness Council of Maine is here to support. I always tell you that help is no more than an email or phone call away. So we appreciate hearing from you, and there's always an answer somewhere. I don't always have the answers, but I can certainly find them. I'm very good at that. And I think that's where we can close it off. I'd like to introduce Marie Stuckey, and she will be here to share with you about Maine Health Management.
So I just want to thank Roxanne for working with me to put this on today, and thank you all for coming in this cold weather. So we worked on this to get you all here together, and I appreciate her help. The Maine Health Management Coalition is a convener of all stakeholders for maximum health care in the state of Maine, and this is just some of the logos of some of our members, but basically our idea is to really work together because everybody's involved in making change. Our multi-stakeholders include purchasers, health plans, brokers, benefit consultants, providers, affiliates, consumer groups, and we have about 74 members right now. Our mission is to improve health and maximize improvement in the value of healthcare services for all Maine residents. So some of you are our members, but I'm going over this for those who may not be familiar with us. We achieve our mission in different ways, and one of the ways that we've done this is by building awareness through a statewide book club through the book Healing of America by T.R. Reid. That was a great success. We had 10 appearances by T.R. Reid, including at our annual symposium, and there was corresponding PBS broadcast afterwards and a lot of media coverage. So our results were over 16,000 participants and over 1 million media impressions. So it was a big success, and it helped get the word out about wellness and comparing the United States healthcare system to other countries. We also get our mission accomplished by engaging health plan beneficiaries and their management, and one of the ways we did that was through a member that came to us, the City of Portland, and said that their employees were looking for a wellness program. So we created this CEO Champions program. Studies indicated that having a campaign from the top down would be the most successful, where the CEOs were leading the charge for better wellness. And so we had kind of a friendly competition among the participating CEOs in the state. We're just finalizing our second year of the program, and had some fun at the end of the last year's program with the NBA basketball star Dominique Wilkins. He spoke and was like a motivational speaker for the CEO Champion participants. He's been having his career while managing it with asthma, so it was a good motivational speech. And we just have a quote here from the University of New England participant that there was just a wonderful improvement at the university as a result of this CEO Champion initiative. And this is just a quick picture of the 2013 participants: Anthem Blue Cross Blue Shield, City of Portland, the Maine Health Management Coalition, University of New England, as I mentioned, and Tides Global. And there, of course, is Dominique Wilkins. So one of the things that we do that is really substantial is we have a great data department where we have clinical claims data from all our members that we can analyze and compare through benchmarks to other companies around the state. So this is just an example of some of the reports we do provide through our providers and for our employers. And today I've brought with me a fairly new member of our staff, who is Rebecca Marciso. She's wave in the back. She's helping our members with data implementation, so learning how to best change practices that our members are doing so that they will have improvement in their healthcare value. Another big initiative we work on is value-based insurance design, and we're working with all the health plans in the state of Maine to develop this and bring it on. It should be available at the end of this year. And basically, in a nutshell, it provides patient with information right at the point of service, evidence-based information about what's the most useful care, what has the best evidence for services that work. It also includes results in high quality care at the most reasonable cost. That type of information is shared between the doctor and the patient so that they make the best choice. And finally, it streamlines administrative costs, which are just out the window. So we're having a webcast on that in March. So if you're interested, let any of us know, and you can register for that. There's a sheet on this in your folder as well. And then we do have our consumer website, Get Better Maine, and here we have provider performance measurement and transparency through public reporting of different services. So we report on effectiveness, safety, patient experience. We've just added behavioral health, and then you can see the list on the left there of new specialties that are coming very soon. So we're very excited about this website and the information that it gives to residents of the state so they can make informed decisions for the best quality care. This is also in your folder, and it just lists some of our upcoming webcasts. The first one is available to register for now. In March, there will be the webcast, as I mentioned, on the value-based insurance design, and that is going to affect everybody in the state. So I highly recommend, if you have any interest, that you do register for that one in particular. We also do have some credit hours available for some of our webcasts, and our members do attend them all for free. Some of them are costs for non-members. That's just a member list, and I won't read that whole list to you. A little long. So let's get to the meat of the matter here. We're really happy and very appreciative to have Wayne Gregerson here from the Jackson Laboratory. He's going to do a presentation, Healthy, Wealthy, and Wise, that was just so popular at our symposium, so that's part of the reason we're doing it again by demand. And then I appreciate everybody that's come here for our panel discussion, Can Workplace Wellness Save Money? Then we'll conclude with a networking dinner. So I'll just introduce Wayne. He has 37 years of human resources experience and currently directs all compensation, benefits, health, and rewards programs at the Jackson Laboratory in Bar Harbor. He's responsible for developing and maintaining a total reward strategy, building and maintaining systems and processes, setting goals and objectives, creating accountability metrics, and many other efforts aimed at decreasing the Jackson Laboratory's healthcare costs and improving their employee well-being. Wayne's strong specialized skills and knowledge in integrated health risk and demand management, consumer-based healthcare, safety and risk management, integrated managed disability, retirement plans, and executive benefits have resulted in significant success. In fact, they haven't had a rate increase in the last 7 years. So I'm sure you're very excited to hear from him, and I appreciate him coming. Wayne?
I'm glad to be here, and you probably recognize Ben more than me because Ben's frontline person on our wellness program, and he's the one who's mostly at these meetings. So all that stuff about me, Ben as well. I don't do it myself.
His pretty face is also on your website.
Pardon?
His pretty face is also on your website.
Oh, okay, good. Great.
Okay, he's up.
Yeah, I think so.
Okay.
Okay, I think I'm fine.
Okay.
So I am glad to be here. A lot of our success, maybe even most of our success, comes out of our being a member of the coalition and the council. So, you know, I steal every idea I can from all of you out there. So, and I hope, I see a lot of you out there are advanced practitioners. So hopefully I'll be able to keep your interest because you've probably been through a lot of this. This particular presentation kind of shows how we built our program brick by brick by brick, you know, step by step by step. So it is kind of that very methodical. There's no genies that come out of a bottle that all of a sudden solve their problems. It's just been brick by brick, building walls as best we can. This is a demonstration of our healthcare costs since 2006, and as you can see, we actually started our wellness program in 2007. And the Jackson Lab was really generous. They gave us a lot of money to do wellness. I mean, I came to work at Jackson Lab in 2006 and had been around for a while, and I never had an employer that was willing to make the kind of investment that they made in our program, And so in 2007, we started, you know, doing all the things that we're doing. But look, as we went along, costs went up. So I'm glad they didn't fire me or take the money away, because it does take a while. There is a lag between the time you start and the time you start seeing results. It just doesn't happen overnight. So you do need to have a patient employer who's willing to stick with you through this. But we got to 2009, and then as you can see, since 2009, we've done very well. Costs have gone down. This last year, they've kind of gone up. It hasn't been a great year, but it hasn't been a horrible year either. I mean, our costs are still a lot less than they were in 2009. The red bar is our total costs, and the green bar is, or the green graph is cost after employee contributions. Let's see if we can do this right. One of the things that really drove our success is our ability to get and use data from the coalition. We really didn't know where we were at when we started as far as data. We got data from Aetna, and all we knew is that our costs compared to Aetna's book of business were a lot higher than Aetna's book of business. But you know, we just said, well, we're in Maine, costs are high in Maine. We have all these older people, you know, we're in the part of Maine that has the highest costs. And so that's why our costs are high, because everybody in Maine's costs are high. But when we started getting data from the coalition, we found out that our costs were a lot higher than the average Maine employer and the average member of the coalition. So we started being able to benchmark against, you know, our neighbors and see how we're doing against that. But this is kind of shows you all this data kind of shows you what our cost and experience was when we started the program and what it was in 2013. We should have 2014 shortly, but you can see in 2013 our costs were $3,743 per member, and in 2007 it was $3,826. So we're 2.2% lower in 2013 than we were in 2007. And you can see all the way down the line our days of care, our admissions per thousand, inpatient surgery. All of those are dramatically down since we started the program. So we're not only seeing costs go down, we're seeing, you know, utilization and go down significantly as well. We do have an extensive program of risk management where we do have biometric screenings every year, and they're highly successful. We get 70 to 80% of our employees who do the risk assessment, and this is the results over the period of years since 2009. The reason we don't have it going back to 2007, it would actually be more dramatic if it was 2007, but we changed health risk assessment tools, and we couldn't get an apples-to-apples comparison, so we started. We now use the University of Michigan health risk assessment. That's kind of the gold standard out there. Who's the doctor at the University of Michigan? Anybody know that?
Was the Eddington.
Yes, Dr. Eddington. So, you know, he is the godfather of wellness, and so we use his health risk assessment for a lot of different reasons. But you can see that our risks have continued to go down in these major risk factors. And we were just talking, Ben was talking the other day about, we just did our biometrics, you know, for 2014. We do it in November and December, and we now have our tobacco uses down to 2%. So we are continuing to make progress there. Population risk, moving people from low risk to high risk, or from high risk to low risk. You can see our low risk population is going up, moderate risk is going up, and high risk and very high risk has been going down. And the University of Michigan Health Risk Assessment Tool, they have a scale, they're kind of a wellness score scale, and where you kind of get a composite one-number score and can compare it to the other users of that device. And so our score is a 90.8, and the average is an 84.9. And we think that's pretty good because probably most of the companies that are using the University of Michigan survey are probably, you know, high involvement engagement companies that are really into this. So we kind of feel like that's really comparing us against our peer companies who are really doing well, and we're seem to be doing better. So that's that continues. We not only measure illness, but we also measure injury and how we're doing with our workers' comp, because they're married to each other. You know, how fit people are is going to result in how safe they are as well. And so we have a really extensive and successful safety program. And this shows you since 1991 how well we've done with safety. This is our experience mod, and those of you who know workers' comp know the experience mod really tells you how your workers' comp compares to the average. So if you have an experience mod of 1.0, that means you're average for your industry and for your demographic. And we're now at 0.6, so we're 40% below companies that have the same risk environment and same demographics. So that's part of our success story as well. So, you know, how did we do it? You know, where did we go wrong? Why were we so, you know, questionable in the first place? You know, what did we know for sure? These are kind of the questions we asked ourselves at first. You know, what risk can we manage? You know, what are the costs associated with the risks? So it really was a risk management program that we've instituted, and that's kind of the core of the program. When we looked at where did we go wrong, you can see we went wrong in a lot of different ways. You know, you know, the more we learned, the more we found out how ignorant we were. We didn't have a strategy. We didn't have strong leaders involved with this operation. We didn't have a plan or a business model, and you know, we weren't spending the time, we weren't spending the money, you know, we might have lacked the fortitude to see it through the long run. So all of these things we had to, you know, get on a table. This is why we're not being successful, and we need to change that. And we set out in 2006 and 2007 to do that. You know, what did we know for sure when we started the program? We knew that the lower the risk, the lower the cost. So that's why we call it a risk management program, is because if we can get the risk down, we're going to get the cost down. And this is a chart from Aetna, and it shows that 61% of the population of their members can be considered healthy, and they incur 4% of the costs. And then you get all the way, you know, acute care, they're 38, acute sickness, they're 38% of the population, 26% of the costs. And then you have chronic, they're 27%, they're 12% of the population and 27% of the costs, and catastrophic 1% of the population and 31% of the costs. So, you know, if we could get more over to that 61% side, we knew we'd have lower costs. So, again, kind of ticking off what, you know, when we were taking this inventory at the beginning, and like I say, I know a lot of you are advanced practitioners, so this probably looks like really basic 101 stuff, but you know, we did do this step by step and brick by brick, so this does help sometimes employers who are trying to start kind of from scratch to kind of, you know, what questions do they need to ask and answer. So, you know, we knew for sure that risks exist, that they can be eliminated or they can be reduced, and we knew there were best practice strategies out there that work, you know, and we could latch onto those, and there they are in the literature. Why don't we do it? We knew that if we waited, it would only get worse, and we also, you know, we always said employees are our most important asset. You know, are we really treating them that way? You know, with our all our other physical assets, we do preventive maintenance, we paint them, we take care of them. We do the same thing with our human assets. So that was important as well, a reason for doing this. Whoops, let's see. Yeah. So then we, peel back the onion in one more level. What risks are we dealing with? Well, we have lifestyle-driven chronic disease, so anything that's lifestyle-driven, that can be pretty well changed, right? We can change that. We had age-driven impairments, and there, we can have an impact on that, but an aging workforce is going to be more risky. You can make it less worse, but it's going to continue to be worse just because that's the nature of human beings. Sickness and degenerative disease, genetic disorders, obviously that's important to Jackson Laboratory, genetic disorders. There was environmental risks, unsafe behaviors, accidents and injuries, and healthcare utilization was a risk as well, as you all know. So these were the risks that we had to go after, one by one, take them on, and find a solution or a system to take care of each one. We knew that, we're looking to find out what were the consequences of the risks. These are all familiar to you: death, disability, accidents. It wasn't just healthcare costs. It was, absenteeism is, as you probably have read a million times, the cost of absenteeism far exceeds the cost of healthcare associated with that absenteeism. So that as well was a important consideration for us as to the consequences of the risks that we needed to measure and take into account. Productivity losses, that we knew that even if we had everybody show up every day, that we were going to have productivity losses if they didn't show up healthy and ready to work. So absenteeism and presenteeism were important to us, and it's pretty well established in the literature that incidental absences account for 80% of absence events and 33% of lost work days. Incidental means Monday morning I call and I can't come to work kind of thing, So those kinds of one-off absences do add up, and they're the kind of absences that can be eliminated. Oops, I missed that one. An employer spends 50% of their payroll on absences, and that's more than they spend on health care. So, continuing to peel back the onion, every day 3 to 6% of the workforce is absent for most employers. Companies commonly overstaff 10 to 20% to account for the employees that are going to be absent that day, so that's a big number. And typical companies set aside 4.4% of their total budget for absenteeism, and it's estimated that poor morale costs companies about 5.5% of their budgets. Presenteeism, obviously, you're familiar with, but 60% of total cost of illness is from employees who continue to work despite their illnesses and impairments. So 60% of the cost of illness is from presenteeism defects. Is again a big number. These are big numbers to go after. And again, when our employer, Jackson Laboratory, sees this kinds of information, it makes them willing to spend the money. So you kind of have to, when you're building your program brick by brick, you have to have this kind of data, because it does, if they start seeing it brick by brick, it all adds up to this big pile that says, the risks are there, and here's the cost of the risks, and they're all things that we can change. So we then looked at, well, what are the controllable risks and what are the limited control risks? We know we can control behavior. We know we can control resources that we have. We know we can change processes and run processes. We have limited limited control on provider quality. I've done this slide a long time ago, but I would maybe move that to controllable because of the Maine Health Management Coalition, because we are starting to be able to affect provider quality. That's not something that was limited control before. Now we're having, through force of numbers with the coalition and the council, we're able to have some control over healthcare quality. But we certainly can't control the macro healthcare industry. External culture, the popular culture is a mess, right? And we can't say much about or change much about that, but we can change our culture. So what we did is, we documented all our risks, and we used predictive modeling to look at the severity of risks and to sort by severity, sort by disease state, sort by medical provider, sort by cost, location, and all of this data kind of narrowed it down, and these are the things that we need to address. And so we do have severity-based strategies. So we have a strategy for those people who are well and are relatively disease-free. You know, so you can't just say, well, you know, they're disease-free and they're well, they can take care of themselves. No, you have to have a strategy to deal with them, and all the way up to, you know, at-risk population, acute illness population, chronic disease population, catastrophic disease population, and as you all know, you know, 85% of the members are 15% of the cost, and 15% of the members are 85% of the cost. So you can see that we developed a strategy for each one of those stratums of risk. So kind of things that, you know, again, if you're building your plan brick by brick, you need to do. You need to have a written plan and leadership. You know, we are really lucky that we have our senior leaders of our company really do get out there and lead. You know, they're out there all the time, showing their commitment to this. You know, by their actions, their lifestyles, and their ability to put up money and get up in front of employees and speak. And so that goes a real long way. We need to establish goals every year and have a written action plan, and we need to make sure, again, that leadership participates in the program. So our strategy included increasing the management capability and accountability, making sure we change the culture. The culture is probably the biggest, as you all know, the biggest key to changing behaviors is changing the culture. And, you know, changing behaviors, change the culture, changing culture, change behaviors, and you know, kind of get them to be our culture at the Jackson Lab to be kind of a lifeboat from the popular culture outside the lab. And so we need to manage, measure, and improve. Some of the things, you know, that we do organizationally is health and fitness issues need to be on regular operational meeting agendas. Local site management needs to know the costs of health, disability, and absence, so they have awareness of that. And health and fitness programs success is an element of managers' and supervisors' performance. So that's kind of the, again, brick by brick building our program. And then now what we're having that program in the context of Maine. So how is it different doing this in Maine and doing this somewhere else? And Maine's healthcare challenges, as you know, is cost. You know, despite all we're doing here, we're still extremely high cost state, you know, for a lot of different reasons. Another important component of Maine's healthcare problems and success is access. If people don't have access to care, either due to poverty or whatever else, that causes a problem. And then the other thing is quality. So these are the kind of contextual situations in Maine that we need to deal with. So why are the costs? Why does it cost so much in Maine? Well, we talked about this. We have a rural, older population. You know, the rural healthcare costs a lot because you lose all those economies of scale that you get with big medical organizations. I came from Chicago in 2006, and I never would have thought this before I came here, but we are very low in per capita income compared to the other states. We're like 36th, you know. And so we are a relatively poor state. You know, we are still a part of Appalachia, and that was a surprise to me. You know, from Chicago where I lived, I thought Maine was all what you see, you know, on television with sailboats and all that stuff. But we have a significant poor population here.
Christmas lights in July.
Yeah. Right. We do have a poor health status with high rates of chronic disease. We have significant cost sharing, as all of you know, uncompensated care for the uninsured, inadequate government programs, cost shifting from Medicare, Medicaid. We have the highest incidence in cancer in the nation. Without, that's surprising too. But I know that one of the things that I learned as well about Maine is that we are the exhaust pipe of the nation. The jet stream takes everything from west to east and comes out exhaust and we have terrible air quality in Maine as other cancer risks. So there's a rising demand, inconsistent quality, poor information, and inefficient, costly care for the uninsured. We all know this about costly care for those who are uninsured. We have a lot of that here. Inadequate care or inadequate government reimbursement. The Maine Hospital Association estimates that for every dollar spent caring for Medicare beneficiaries, the hospitals receive 85 cents, and obviously we all then pay the 15 cents. And for Medicaid beneficiaries, it's worse. They receive 76 cents on the dollar, and thus we're subsidizing that by 24 cents. So a lot of our money, no matter how well we do, we're having to subsidize all of this unreimbursed care or not reimbursed enough care. I know with the Affordable Care Act, probably many of you probably have just gone through the calculation of calculating what your taxes are going to be to subsidize what I think what they call it the stop loss insurance kind of premium that you have to pay for the Affordable Care Act as part of your income tax filing next year. The Jackson's Labs is $250,000 that we just have to send off to the Affordable Care Act through the IRS. It's the IRS that does the taxing. But no matter how good we do, we're sending the Affordable Care Act $250,000 because they have to support the risks that aren't being controlled. So it really is hard to get a hold on this as a result of that. Again, the Maine lifestyle, this is how we like to see ourselves, out there in kayaks and exercising and camping and climbing, but this is who we really are. So Ben, thanks for the slide, Ben. He gets prior to 2007, when we kind of started doing all this, we were doing the same thing other employers were doing. We were increasing cost sharing to employees, more deductibles, more payroll deduction. We were incenting prevention, so we were doing that. We had telephonic chronic disease management. That's been around for a long time. Insurance companies have been doing telephonic case management since the 1990s. I don't think it worked then, and it doesn't work now because it's hard to do this on the telephone. People don't answer the telephone. They don't have the right numbers, just as a start. Complex case management, we did that like most people. We had EAP. Obviously, we participated in Aetna networks, and we kind of said, well, we have a wellness program. What we've kind of done since 2007 is one of the first things we've done is join a coalition. We weren't members of it until 2007, and so we went to a meeting. Maybe it was a meeting something like this, and we decided we should join. We re-engineered our wellness program. Our wellness program is called Jack's Fit. We started to have some innovative benefit designs, tiered networks. We do based on Maine Healthcare Coalition data. We do tiered networks based on quality, so that if you go to a primary care doctor that has a blue ribbon, then you get a lower copay than if you go to a doctor that doesn't have a blue ribbon. Providers of Distinction program, that's actually for specialists. We use Aetna's program for Providers of Distinction, which is called our Excel program. So we do incent people to use the higher quality specialists as identified by Aetna. We do have Providers of Distinction Hospital, which is St. Joseph Hospital, which is 45 miles away from us, but we do incent employees to use St. Joseph Hospital. If they use St. Joseph Hospital, they get a 95% reimbursement. If they use any other hospital, they get an 80% reimbursement. And it was a result of us actually doing an RFP to the hospitals, and they came out to be the lowest care, highest quality hospital. So we said, "You're it. You won the bid, and you can take care of our employees." We do use St. Mary's for joint replacement, hips and knees. We pay 100%, and that's at Lewiston. So we send our employees to Lewiston to do hips and knees. We save a huge amount of money, and if anybody, you've been to St. Mary's Joint Replacement Center, it's just phenomenally good, and we get a flat rate price, and it's wonderful, and our employees love to go there, and they do so good, they don't have to stay. I mean, we pay for their family being there, we pay for room and board, meals, travel, and they generally only can come home in a couple of days and have physical therapy back on MDI. So we have partnered with regional providers, and we do now have St. Joseph Hospital has actually a primary care physician office on site in our Bar Harbor campus, and St. Joseph also has occupational health with Workwell on our campus in Bar Harbor. Maine Health Management Coalition, you know all of this, but if it wasn't for the Maine Health Management Coalition, we wouldn't have had the data, the convincing data that we needed to go and talk to the providers and do RFPs. So when we got our first data from the coalition in 2008, we found that our costs were 25% higher per capita than the average member of the coalition. Now, part of that is the average member of the coalition is in southern Maine, you know, as far as numbers, and as a result, you know, you pay a lot less in these heavily populated areas of Maine with the bigger healthcare facilities. And so what we did find is that a lot of that was due to price, that we were paying that much higher a cost as a result of higher prices, because when we looked at, when we kept drilling down, we found that, you know, our costs other than hospital costs were actually cheaper than the coalition, but our hospital costs were 50% higher than the coalition. So we were, you know, it ended up 25%, but where it started was our hospital costs were 50% more expensive. You know, so this is what we went to our local hospitals with, MDI Hospital, Maine Coast Memorial Hospital, Blue Hill Hospital, Eastern Maine. We went and we said, here's the data, here's where we are, you know, and it was our CEO who went there too, and our COO, Chuck Hewitt, and sat there eyeball to eyeball with their top management and said, you guys can't do this to us anymore, you know, and we're not going to put up with it anymore, and we're going to put our business out to bid, you know, and there was, Ben can confirm this, there was a lot of front page news stories in our local newspapers about this war going on between the lab and the hospitals, and there were these long letters to the editor that were being fought by the hospital management on one hand, sending letters to the editor, and then our executives sending their letters to the editor, and they were really scrapping pretty hard. We're all friends now. Everything is much better, much better. We recently got the most recent data from the coalition, and the good news is that our utilization of healthcare is about 13.5% lower than the coalition. But we're still paying 5.6% higher on average than the coalition. So you can see that even though our utilization is way down, our costs are still a little higher, but they're not 25% higher. You know, so and we are in a bad place. This is infuriating at our local hospitals, but we are in the ground zero of high-cost healthcare in the world in our little Bar Harbor, because you know you consider Maine is, you know, what, third, fourth, second, whatever it is, highest cost healthcare state in the union, and as you move farther north and you get more rural, we're way more expensive by price, you know, cost per service, way higher in cost, you know, where we live in Maine. So if we're the highest cost by price in Maine, and Maine is the highest cost, and America is the highest cost in the world, then we in Bar Harbor are the highest cost hospital in healthcare in the world. You know, they get really mad about it. This again comes from our first data from the coalition. It shows what the prevalence of disease was in 2007, and what the cost per capita was. So for musculoskeletal disease, we were 17% lower in prevalence, but 18% higher in cost per capita. And you can see all the way down the line, gosh, we're healthier, you know. But you know, we're paying so much more than everybody else. This doesn't look like it's right. So again, this is information we took to the media, to the hospitals, and fought our battles with the facts that we got from the coalition. So again, this is an advertisement for the coalition, so we're happy to be an advertisement for the coalition, because most of the ideas we got came from the coalition, so we're happy to give that credit to them. A little bit more about our provider distinction program. Again, tiered networks, lower co-pays if you use a network provider, and St. Mary's. And also, we have a partnership with the Center for Connected Health Partners Online, specialty consultants. This is the Harvard Health universities and hospitals, teaching hospitals, and their top specialists in the world will do second opinions, via the phone and the internet, and so we encourage our employees to use this Center for Connected Health to get a second opinion, and they can get a second opinion on anything for free. We make sure that our employees don't, and we do this through Aetna, don't have to pay anything for this second opinion. So we always say, just like the Red Sox are in Boston, and we can have the Red Sox for us here, the best healthcare in the world's in Boston, and you can have access to the best healthcare in the world to get a second opinion, just like you can cheer for the Boston Red Sox. So we do encourage people to use that, to work with their doctors, to have the data sent via the web to the Harvard Medical School, and to get back information. And people who go through this, 90% of the interactions recommend changes in treatment. 90% recommend changes in treatment, and 5% result in a new diagnosis. Yes?
And is that data, with that statement being shared back to the treating physicians up here in Maine?
Yes, yep. And actually, we've got Dr. Resnick from St. Joseph Hospital is the St. Joseph primary care physician that we now have on site, his office, and he's really interconnected with this. So we really encourage our employees to see Dr. Resnick, because he'll get them hooked into this right away. Quest Diagnostics, that's one of the things. For rural hospitals, you probably all know that that's their real profit pocket is lab work, and they will charge unbelievable amounts of money just for basic lab work. I mean, $700, $800 for what we can get with Quest Diagnostics. We get for $70. So we do pay for lab work that's done by Quest Diagnostics at 100%. We tell our employees, when you need a lab test, and your physician writes that out, that's just the same as a prescription for a drug. Just when he gives you a prescription for a drug, you can go to any pharmacy you want. If you get a prescription for a lab test, you can go to any lab you want. You don't have to go to the hospital lab that the doctor's associated with. So we will do blood draws on site at the lab and send it to Quest. We have kind of beat down the hospitals a bit. They now say uncle, and if our employees ask them at the hospital to send the blood to Quest, they now will do that, and then we pay employees at 100% to have the Quest Diagnostics. Last year we put in place WellMatch. It's a service from Aetna. You can't see it on the Aetna website. It's a subscriber service, but it allows our employees to go online to WellMatch and match price and quality online for a wide range of procedures. If you go to if you're an Aetna customer, you go to Aetna's website and a regular comparison engine on their site, they only got like this many procedures. But if you go to WellMatch and you pay extra for that, you're able to see for many hundreds of procedures what the price differential is between hospitals and doctors, and it's very dramatic information that people find, and so we encourage our employees to use WellMatch, and it does show them not only the difference in cost, but it shows them what their actual payment out of pocket will be based on their specific health plan. So it's a lot of they know if they go to St. Joseph, they're going to pay $10, $100, $500, and if they go to Eastern Maine, they're going to pay $5,000 or something. So good information. This is an example of hernia repair at one hospital, $632, at the other hospital, $2,000. Again, our program is, our wellness program specifically is Jack's Fit. This is the kind of the goals of our wellness program is, you know, to improve health, prevent problems before they occur, detect problems, you know, prevent problems from getting worse. We are lucky that our employer was willing to spend as much money as they spent. We have a very much state-of-the-art large fitness center on MDI. We also have one in our Connecticut location and our Sacramento, California location. Our program, our wellness program is kind of organized around Passport for Better Health. We stole that from Bath Iron Works, and I think we've made a lot of improvements to it, but we stole it from them. And so people get a passport, you know, kind of looks like your little passport, and in it, it has kind of wellness places you can visit, and you get stamped just like a passport as you do those things. And then, and then you turn your passport in, you get health incentive credits, and you can use those health incentive credits that flow right to their Aetna plan, and they can use it to buy down their deductible to basically to zero. So they don't have to have any health plan deductible if they earn enough health incentive credits. Again, we do biometrics every year. We have significant participation, and what we do is when we get all that data, the employees, doctors inundated, the chronic disease management division of the hospitals get all that information, the primary care doctor, our outside chronic disease management program manager gets all that data. And so it's shared with all these people who can intervene with the employees and do something about it. So the employees aren't the only one who gets the data. All of these risk management resources come down and are able to evaluate the risks of each individual that they're responsible for. We do have on-site chronic disease management nurses that we have the local hospitals send their disease management nurses on-site to see our employees, and they make appointments, so our employees don't have to go to the hospital. They just have to make an appointment, and those local hospitals have the nurses on site. We also do have on-site lifestyle coaching. This is an example of the health incentive credits that people can earn, that they can apply towards their deductible. And so when they complete the HRA, they get $300 off into their account, $500 if they do the biometric screening, $400 lifestyle coaching. So all of these health incentive credits go into a bank account, and they're drawn down whenever the person needs it to pay their deductible.
Quick question.
Yes?
Do those add up over the course of a calendar year and then are applied the following year, or is that done in real time?
Yeah, no, it's done in real time. It's done in real time. Yeah, and actually a lot of them don't require any intervention on our part. Like if a person gets a preventive exam, Aetna will automatically capture those points when they get the bill, and they'll automatically flow over. Some of them, if like some of the things they'll earn the points, but they come through the passport program, which results in us having to kind of communicate to Aetna and say, here's the points, and it might take 4 weeks or something by the time those points get there. But once they get there, they're there for the year, and we used to allow them to carry over unlimited points, but this year they only allowed to carry over 1 year's worth of points, and they can't carry over any more than that. But you know, there were some people who were just getting globs and globs of points, and it got to be ridiculous what their balances were. So you know, can't do that anymore. So some of the initiatives for 2015 now is we continue to look at teledoc and local 24/7 care. You know, when you're in a rural area, it really is hard to get after-hours care. So that's something that we're working on. We're working with our local providers on e-visits, you know, so that people can use the internet and email to interact with each other. We did a test pilot program with Aetna called Utopia, and what happens with Utopia is people who have what's it called? What's that syndrome called?
Hypertension.
No.
No. Anyway,
Yeah.
there's this syndrome. It's basically,
Hyperlipidemia.
pardon?
Hyperlipidemia.
Something like that,
Yeah.
And so anyway, it's if your biometrics hurts, hit certain, like your triglycerides, your cholesterol, actually also your waist measurement, metabolic syndrome, that's it. And so people who are likely to have metabolic syndrome identified through the health risk assessments get their data referred to Newtopia. Newtopia looks at that data, and an employee sign up to be able to release the information to do this. When Newtopia gets that information, they send an information kit to the employees, and the employees spit in a little tube, send it back, and they get a genetic analysis of their condition, and then they get assigned a coach. So they're actually working with the specific genetic information supplied by the employee, and they use that to coach the employee in reducing that metabolic syndrome. So that was a pilot we tried with that, and we're still looking at the final results. But of the people who participated, it was hugely successful. I don't think we got enough to participate, but the people who did, it was very, very good. Again, the WellMatch program, and of course we're involved with accountable care organizations, which is the big new thing. Well, the big thing, not new anymore, but I hate, people don't like to say HMO, but it is kind of HMO on steroids. It's everything that the HMO should have been, but wasn't. And so we are working actually with Eastern Maine Medical and their local other healthcare organizations to create what we're calling the Down East Accountable Care Organization. So, in conclusion, health risk management broadens health cost control, and we can manage the total cost of risk if we do it as a risk management program. That's it. Thanks. So, would you like me to? What's next? Do I answer questions, or do I?
Does anybody have any questions for Wayne?
Yes, I'll start.
Oh, yeah. That severity risk strategy that you brought up for your organization, how does that work inside? Who controls that? Is that an ongoing strategy? Putting?
Yep. I mean, we just make sure that we recognize that each level of risk needs a different strategy. That you can't use for well people what you use for chronic disease people necessarily. So I think we're conscious of making sure that we have a solution and resources for every different kind of risk level that we identify.
So, like for example, if someone was newly diagnosed with diabetes and they were willing to share that with the organization, they would have the resources to be able to deal with it.
Yeah, and they don't have to share it with us. I mean,
You have a TPA?
Pardon?
Do you have a TPA, a third-party administrator?
Yes.
Oh,
yes.
okay.
Yep.
Okay.
Yeah, we don't. We try to not to have access to personal health information. So we use probably everybody knows Tracy Allen. Everyone knows what's Employee Health Solutions. Tracy Allen is the organization's Employee Health Solutions who handles all of our data for biometric screenings and things. So she gets the data from the screeners, it goes to her, she prepares a packet that's mailed to each person's home that has the results of their biometrics and some analysis about what it all means. And it's through that data that also gets streamed over to all the intervention resources who then contact the employees and kind of close the loop and give them the opportunity to address those risks.
With that on-site clinic, are those primary care providers at that clinic?
Yeah, yep. We have about 1,300 employees on-site in Bar Harbor, and we now have we almost 500, 450, something. 450 employees are actually now using our on-site clinic as their primary care doc. So, yeah, and he loves it because because usually a practitioner has about 2,000 patients in their practice, so he's got 450, and he just loves having the time to spend with people. he'll spend a lot of time with people. Any other questions? Yes?
If I understood correctly, you said if your employees go to St. Joseph Hospital, 95%
Yes.
of the cost is covered. So what do you do for care that's not offered at St. Joe's, maternity, pediatrics?
Yeah, I mean, kind of what we tell people is we say, you know, we made this deal, but it's not for everyone, every time, every place. We did the best we could. We have this alternative. If you can use it, use it. You know, we warned them against the cost of shopping locally, but they still had the choice in the end. And, you know, anybody who lives on MDI, they have to drive 45 miles to do everything. So it's not as bad a trip. And now with Dr. Resnick on site, being the primary care doc, it makes it even easier. So. Any other questions? Yes?
Wayne, as you look at your healthcare cost savings across the spread of healthcare costs, I sort of have a two-part question, and I think they're related. So the first question would be, what aspects of your wellness program would you directly attribute to your cost savings?
Well, you know what? One of the things we found is there is no silver bullet. You kind of can't say this is the one thing. And that's why we do so much, because we try to meet everybody where they're at. You know, and I think we have a big funnel, and we try to have as big a funnel as possible to get everybody in. But once they start going through that funnel, then where they fall out of the funnel depends on who they are and where they're at and what they like and where they live and how they eat and all the rest. So we have many, 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 many choices for people to have interventions, and so that they, you know, some might make it all the way to the bottom and fall out to whatever resource that is. Some might fall out over here. But we give people a lot of choices. And I think that and the choice they feel comfortable with many times turns out to be the most effective choice for them. So I think that's one of our major lessons, is there is no silver bullet. You got to do so much, so right, so much of the time to win. It's really, as you know, full-time job.
The second part of my question would be, when you look at your various wellness program components, which component of your program do you feel has the greatest impact on your costs?
You know, I think we have, I think our I'm going to put the big umbrella health coaching is probably the most effective thing, because we do have many different coaching alternatives available to employees. And so we have a large number of employees who are seen by some kind of health coach, a chronic disease management coach, a lifestyle coach. Ben, I don't know, what would you say?
Yeah, I would say the same. I mean, I think it's really our lifestyle coaching, and then it's our chronic disease management coaching program. And what's great is working with our local hospitals, because working with MBI, they bring a whole kind of medical home perspective to it. So if you fall within their envelope, then depending on what your metrics are, your biometrics and your risk, they're providing you with, you know, a disease manager, they're providing you with a nutritionist, potentially, you know, a health coach as well. Maine Coast provides a disease manager, same with St. Joe's. So it's getting those folks into the right pieces and programs. And then it's, you know, I'll have, you know, folks say, you know, they'll call me up and say, you know, I have a friend who's seeing a nutritionist from MBI. Can I get in on that as well? And, you know, we do kind of soft handoff referrals that way. And it's kind of word of mouth and very organic.
Yeah. And we felt extremely honored that we had the CDC come to visit us. And they came to visit us because they had kind of heard our own blowing our horn like this, right? And they kind of heard about us. And actually it was actually an article about the coalition's symposium. And there was an article about the symposium. I did this at the symposium. The CDC guy read about it. He called our CEO and said, I want to, you know, I'm from the CDC, I want to come visit you. I want to see what you're doing. And so the guy came visited us. And the CDC is so huge, I guess, that this guy had this one little niche of worksite wellness programs at the CDC, which was activity. How do you get people to be active? That's what his whole section of the CDC was about. And so he, you know, one of the things he saw was that we had a young woman who lost tons of weight and became a, marathon runner and is really into that now in triathlons and everything. So one of the things, he wanted to see her when he came to visit us, and we did have it, she was kind of the star for him, but that's what he wanted to know, is how do you get everybody moving? And Ben does a great job there. We have, at our, our fitness center, we have 500 unique names that use that fitness center every quarter. We measure it on a quarterly basis. And out of 1,300 people, having 500 use your fitness center regularly is a really good thing. So I think we worked with the University of Maine right here with their Big Bears, Little Bears program. That's what they call it. It was Big Bears to Little Bears. So you start this big chunky bear and you end up with this nice skinny bear. And so they had that program here. Ben brought it over to the lab, and we started creating Big Bear, Little Bear teams at the lab, following the same trainers, schedules and things. The young trainers here that were students and everything became trainers at the lab, and we competed against the teams at the university and the teams. And we have hundreds of people who are in the Big Bears, Little Bears program. It's the most popular program we have, and it's a pretty intense program, right, Ben?
Yeah, we just did sign-ups today, and it's gotten to the point where it's sort of like the day after Thanksgiving at Best Buy. And folks are, we'll fill up pretty quick, and some folks will stop by and say, well, did that person pay? Because we ask folks to pay just a nominal fee. And I'll say, well, no, but they've signed up for this time. Well, it's like, well, if I pay you right now, will you pick them out of that? So, I mean, it's pretty cutthroat, but we have a lot of fun, and, it's a lot of, it's fellow employees being together. And I think, for me, the best story was we had a woman who had been at the lab forever, and she parks her car, she walks into her office, she eats her lunch in her office, she goes out to her car at the end of the day, she goes home. And so she investigated, she joined, and then she was like, oh my God, there's something else outside of my office. So she met, 7 new people that she had no clue, so she was able, she has lunch with them today. And I mean, that's just one great anecdote story, just from a social aspect or culture related. And then we've got folks who will do a couple of rounds, and we have one gentleman, I think he was down 70 pounds after 2 sessions. So it's a fun program.
Any other questions?
If nobody else has a question, I got one more, but I think there's one over there. Go, Jamie.
Has Aetna been your TPA all along?
Yep.
And have they been really flexible throughout your journey?
They have. They have. The Health Incentive Credit Program, it became a major part of our program to keep score and everything, and they had that for us, and it's all, we did like, here's this scoring program for wellness that's wired into the health plan. It was really worked really nice. And also, I forgot to mention, we're doing the NutriSavings program starting this month. So I don't know if all you know about NutriSavings, but NutriSavings is a new organization that scores your shopping for food. And when you have your loyalty card from Hannaford's or whatever, when you go to Hannaford's, you buy or Shaw's, you buy your basket of food. You put through your loyalty card, and what happens is once you're signed up with Nutrisystem, all of your shopping information goes over to Nutrisystem. And they are big data. They have data on hundreds of thousands of foods, and they will give you a basket score. And they will say, the best basket score is 100. So if you just, bought broccoli and lettuce or something, you'd probably get 100. But you can go from 0 to 100, and then you reward people based on their basket score. So they get, if they get a basket score of 70, you might give them, this, or you get a basket score of 50, you give them that, whatever. But, we just are initiating that, and we're really excited about it.
It's interesting, I've seen that at the Ellsworth, Hannaford, but not in Bangor.
Oh, yeah, and in Ellsworth, it's for Maine Health employees.
Yeah, I know.
Well, Maine Health is not in...
So I figured you guys were up to something.
Yeah.
Can I ask, having a devious mind though, couldn't I put and ring up all my good stuff get my 100 things, so I'm great, and then ring up separately, my Twinkies and
I don't, well, yeah, if you ran one, if you use your loyalty card on one,
Yeah.
your good stuff, and you didn't use your loyalty card on the bad stuff, then you could circumvent that. You're the first one that has thought of it.
She's always the first one.
I got it at every meeting somebody asks.
Yes.
One of your numbers on one of your slides jumped out at me, and it was the 2006, 2007 data with your comparison with the MIC data. 3% higher incident of mental health issues. Do you ever thought, as compared to the coalition, do you ever thought about that?
Yep. We do have a depression problem. And there's a lot of reasons that go into that. One of it is that you're in Maine and you have light deficiency. I mean, it's just a fact of life, you know? So, you know, right now it's cold, it's dark, there's no light, and so that's a big thing. The other thing is we have people from all over the world in our laboratories, and they're cut off from each other because we're 1,300 people, but we're all exist in these little boxes. You know, each lab is a little box, and they see their 5 people in their lab and 10 people in their lab. And then we have mouse rooms. You know, each mouse room might have 30 people in it. So all these people aren't interacting with each other. So it's people away from home. They don't know too many people. They're lonely. You know, it's dark, and so it's a big objective of ours is to attack depression, and we do have this what we call Let There Be Light program, and we do sell those, what do you call those? SAD lamps. We do sell them to employees at a significant discount. We sell them at $100 under what Amazon sells them at. And so, and we will give them the free. If people can't afford them, we give them free lights. So,
there's a concept that originated in Europe that's now really getting hot in Canada, and I'm pushing it here in the U.S. called workplace mental health promotion, and that might be something you guys want to look at.
Yeah, that's an area that we have a blip that we're higher than average.
It fits very nicely with worksite health promotion. That's why I like it.
Terrific. Talk to you about that. Any other questions? Yes.
So we do have a whole panel that's come here to talk, and there'll be plenty of time for more questions, but I just want to, thank Wayne and move to the next portion of the program. So